Welcome to Clyde Medically Speaking. Each month, we'll explore a variety of topics to help you better understand certain medical conditions and treatment options. Today's guest is Dr. Sonya Noor, a leading surgeon at the Gates Vascular Institute. Today, we'll be discussing the topic of wound care and the growing wound care center at the Graff Memorial Hospital. I'm Mike Hughes, and this is Medically Speaking. Dr. Noor, thanks for joining us today. Today we're going to talk a little bit about wound care and some of the treatment options, but just for clarity, what is wound care and what type of wounds are we referring to?
It's a great question because we're talking specifically about wounds in older patients usually. They usually are diabetics, have high blood pressure, high cholesterol, and usually are diagnosed with having some kind of coronary artery disease, which means plaque in the heart or plaque in the brain, like they've had a stroke. And that particular disease population also are usually chronic smokers. When those patients have wounds, they don't heal as easily as other people. So there are certain special things we do for those patients, and we're talking about specifically those wounds. So it's usually on the feet. It can start as a blister or a burn. Any wound that's not healing after a 4-week period needs to be seen by a wound care specialist.
For those who wouldn't know, what is a wound care specialist? Are they surgeons? Are they primary care docs? Is there some sort of interventional specialty that you have? So what is a wound care doc?
So a wound care doc today is different from what it was even 5 or 6 years ago. And so we're really trying to become a multidisciplinary team that looks at your wound, because turns out wounds are not just wounds. If it's a burn wound or a incisional wound that came from something, that's different. But in this disease population, because there's so many other things going on, a wound care team is somebody who will attend to all of that. So it could be somebody who is a podiatrist who looks at a foot wound, clips your nails, looks at your toes, starts wound care, a general surgeon who may offer some more debridement or some more special wound care treatments. And then the wound care team will also have an infectious disease person. So if you have infections, the appropriate antibiotic and wound care is started. And lastly, a very important part of the team is a vascular surgeon, for example, who will evaluate the patient for vascular supply. If there isn't enough vascular supply, the wound doesn't heal, immediately that patient gets referred to a vascular surgeon, which otherwise they wouldn't get. So all these extra hands get to touch the wound a lot sooner in a wound care center versus outside wound care.
Sure. You're the vascular surgeon. By the time the patient gets to you, what's the typical treatment plan? How many visits? How long do you see them pre and post surgery? So give me a sense of that.
So that's a great question. If you look at statistics and if you look at the dollars that were spent on healthcare and you look at cardiovascular medicine, in cardiovascular medicine is heart attacks, strokes, and what we generally call peripheral arterial disease. It's really the same thing. It's plaque in the artery in people who have high cholesterol, blood pressure, smokers, diabetics. If it affects the heart, it's coronary artery disease. You have a heart attack. If it affects the brain, there's plaque in the artery, it closes it off, you have a stroke.
Sure.
If it affects the arteries, it's called peripheral arterial disease. If you did a subgroup of how much money we spent on it, last year we spent $400 and something billion. Peripheral arterial disease, the category of amputations, which is what happens to wounds, 50% of wounds end up with amputation. Spent the most amount of dollars because it is expensive in care, apart from being devastating to the patient. So the whole point of wound care and early wound care, going to a wound care specialist, is to bridge that gap. We want to see patients sooner, see the vascular interventionist sooner, so that they don't get to the point where they have to have an amputation. Statistics also show less than 50% of people who have an amputation never even saw a vascular surgeon. That's what we're trying to stop. That's what we're trying to get better at. So in the community, you could have a wound. We see wounds on patients who have been treated for a year, 6 months, and then the light bulb went off. Maybe they have a vascular problem.
Right.
We're trying to grow awareness to say this is all an integral part. It's all part of the same disease. We need to evaluate you, see if you have a problem, and then treat you sooner. And in the case of a vascular surgeon, for us, coming up to DeGraff, seeing those patients, we then evaluate them. If they need something, usually it's a really simple fix. We take them down to GVI. It's an outpatient procedure. It's almost always minimally invasive. which means no general anesthetic, just local anesthesia, small puncture in the leg artery. Go in, clean it out with a balloon or a stent or one of the new, devices.
Sure.
Don't even have to stay overnight. You're out the next day. You're back on your feet in a couple of days. Didn't really disrupt anything, but your wound heals in less than a month.
Right.
Then we know we did a good job.
You mentioned the community before. If you look at Western New York, the 8 counties of Western New York, there seems to be a higher incidence of stroke and heart disease, and a lot of that's based on lifestyle and genetics. Is that the same for peripheral arterial disease as well?
Exactly the same.
So talk a little bit about what some of those risk factors are, the reasons that it's a little bit higher in this area.
There's a lot of research about why it's higher in this area. There's multiple, probably leading reasons why. Obesity is becoming a problem all over America. But if you look at the pockets of obesity in the Southwest, it's very high. That's usually related to diet. Our diet isn't as bad as theirs, meaning not as much as fried fatty food. The activity level is a little bit different. It's very hot down in the South. People aren't as active. And they have this genetic predisposition to diabetes. Here, we think it may be diet somewhat, but mostly it's got to be some sort of a genetic predisposition right around this area. So the stroke rate, it's called a stroke belt. It's part of the stroke belt. And it's funny, it jumps from the southern part of the US, there's a big gap, and then right up here it's bright red again. So the two ends of the continent is bright red. Be as it may, people here are at risk for strokes, heart attacks, and PAD. And there's a lot of awareness, and American Heart Association, they've done a fantastic job with awareness of a heart attack and a stroke, but PAD has slipped through the cracks. Even though it doesn't kill you, it takes away your independence. I mean, an amputation is devastating to a patient. You completely lose your independence at the age of 70 or 75 or 80. You can't get up and go to the bathroom on your own.
Right. Somebody's
got to help you do almost everything until you train to be stable enough to use a prosthetic leg, which more than half of the people can't do. Less than 50% survive 5 years after an amputation. So it's a symptom of a general disease.
Right.
But there's not enough awareness around it. People just think it's another wound. It's not another wound. Your body's trying to tell you something.
You mentioned the Gates Vascular Institute before, treatment of stroke, treatment of heart disease, but it's the Vascular Institute, and that's a place where cutting-edge things are happening for PAD. Talk a little bit more about the GVI and its importance.
Well, we're trying to service patients a little bit better by coming to DeGraff, so we see the patients there. So we know that there's a big community following there, people who live in the northern towns, they like to stay in that area. So as a service, we come there, multidisciplinary team, we evaluate the wounds. Some of these wounds then need to be treated with a little bit more vascular intervention, which cannot be done at DeGraff. So we take them to GVI, Gates Vascular Institute, which again is a multi-specialty organization. But the beauty of GVI is being able to do all this new cutting-edge technology, minimally invasive, overnight stays, no anesthesia, no blood loss, no ICU, and in and out in a day with the help of all this infrastructure that we're able to have. Plus, while you're there, if there's something else going on with your heart, brain, whichever part of your body, we can at least start the screening process, hook you into the system, and now you know who to go to and follow up on that.
Right. The DeGraff GVI connection, almost like a hub and spoke. Talk a little bit about DeGraff and its importance in this kind of emerging profession of wound care.
In DeGraff, right now, we have a wound care team, but we really have some loyal, sincere nurses. And the nurses take care of the patients so well, the patients don't want to go anywhere. So the patient comes in, gets evaluated. Some of them have wounds that would require just wound care for, let's say, once a week for 4 or 6 weeks. The nurses can do that. A doctor supervises that, works out well. When a doctor evaluates the patient and the patient needs a little bit more, they're getting both the care of the wound care without having to go far. So they're staying at their place because it's once a week or twice a week. But if they need something, plastic surgery, vascular surgery, they can go to Gates, get the procedure done, and then return back and continue their wound care. So from a patient service standpoint, it's very convenient and it works out very well without them having to go, for example, downtown once a week or twice a week for wound care.
And what you described almost seems like a team concept, and that's something the patient probably isn't focused on or thinking of, but talk a little bit about the importance of the team concept, physician, nurse, frontline staff.
Frontline staff, they're rock stars. They are so invested in Roxanne specifically, so invested in patients, patient care, getting back to them on time. I mean, it's amazing how good she is with them, how patient she is with them. They're older. So the staff and then the nurses both will just, they've gotten to know the patient. They have such a good relationship with the patient. It's a trusting environment. They feel like they can call them, ask them stupid questions. And then there are the physicians, even though, you know, we're there only maybe one day a week, because of them, we're able to build that trusting relationship with the patients, get to know them, and then treat them accordingly. If they ever feel like they have another problem, they're referring their friends now, they're referring their family.
Sure.
They come back and they'll talk to us about a different wound that just started. We can catch it sooner, we can treat it.
So wrapping up for those watching, give us some advice if you have, because wounds can be a life-altering issue for someone. Give us some advice for someone who may be at risk or someone that may be dealing with this right now.
So if you're diabetic, chances are you have a little bit of neuropathy, which means your nerves don't sense as well. That's a typical complaint we get is, I didn't even realize I had a blister, or I burnt my foot. It was winter, I was cold, I put something on it, the heating pad on it, fell asleep, there's a wound. So diabetics in particular, watch out. Otherwise, it's that hypertensive, which is high blood pressure, high cholesterol, smokers. You're not going to heal as well. You will have some sort of plaque formation. Throw in with that diabetes, it accelerates the plaque formation. If it's in other parts of your body, if you've had a heart attack or stroke, chances are you have PAD as well, so get screened for it. And if you see something on your wound, on your foot, see a podiatrist if you're a diabetic. That's probably every 6 months, those are the guidelines. And then on top of that, if you have a wound and you see it in between the cracks of the toes, on the nail bed, wherever it is, and it hasn't been healing, it's been 4 weeks, come see us.
Sure. Well, thank you for joining us today.
Thank you, Mike. Thank you for having me.
Thank you for joining us on Medically Speaking. I'm your host, Mike Hughes. We'll see you next time.